Yes, thank you so much, Stephanie, for such a lovely introduction. This is my third Tiger UK meeting, and I enjoyed each one of them. I think it's a really great space for clinical and non-clinical like-minded people to come together and sort of discuss, share ideas, and collaborate. So thank you so much for the invitation. So I think I will start so we have enough time for the discussion afterwards. So for those of you who've not met me yet, I work as a lead nurse for outpatient hysteroscopy across two hospitals, Chelsea Westminster and West Middlesex Hospital. And I also lead on conscious sedation service in ambulatory gynecology. And I'll do a quick talk about pain relief options and about how we're moving sort of away from old school hysteroscopy and bring in sort of modern solutions for women, for patients. So just briefly, most of you know, but what is hysteroscopy? It's a relatively quick procedure to evaluate inside of the uterus for either diagnostic or treatment purposes. Pain levels vary widely. Some women report pain is mild to moderate, but we know that others would report moderate to severe pain. This experience can also include pain, anxiety, and vulnerability. Now, another important element that we'll talk about is the consent. Hysteroscopy is a very invasive procedure. So the UK emphasizes informed choice and consent for all patients. But does this reflect patients' experiences? We can talk about it later. We know that the guidance say as well that procedure can be stopped at any point when it becomes too severe or too uncomfortable, but is it always the case? Informed consent and trauma-informed care essential for ethical practice, not in only hysteroscopy, but in all gynecological procedures. And it's a process, is not a signature. So the consent to be truly informed requires capacity, knowledge, understanding, and ongoing dialogue throughout care until the end of the procedure or an appointment. So what is currently available sort of across the country? So widely available options is sort of oral analgesia. So we all know about paracetamol and ibuprofen, which RCOG recommends to take it an hour before procedure. Now, just to quickly touch on that, I think there is nothing else you can say exciting about paracetamol, but actually you can. When we have ladies in clinic who come for procedures and they forgot to take paracetamol, or maybe they didn't have it at home, and then what we automatically do, we would offer paracetamol in clinic. Oral paracetamol tablets. Now, I was looking into that, and actually a while ago, I thought, let me check what is the onset time for the effervescent paracetamol if we're giving it to women in clinic. Well, it's 15 minutes. So if the woman arrived in clinic and you're trying to be really helpful and giving her paracetamol if she didn't take any, it will only work after at least an hour of taking it, by the time she'll already be on her way home. So actually just thinking even about something simple like paracetamol, are we always administering it correctly? So just like a little think for just to think if you are a clinician and if you're administering paracetamol on site in your clinic for someone who didn't take it, effervescent paracetamol works after 15 minutes. So that is a good option to have in your clinic. Ibuprofen, slightly different. It takes about half an hour if you take a liquid option for ibuprofen, and the oral ibuprofen onset is about 45 minutes. So not such a big difference. Then local anesthetic is also widely available. It can be administered either cervically or via the uterine, into the uterine, into the fundus. But it's painful to administer. It's an injection, and you require to use more instrumentation, such as speculum and some sort of forceps to stabilize the cervix. General anesthetic is also very widely available. However, we now know that there is a lot of push to almost eliminate it. I think at the current recommendation is to do almost 80 to 90% of all hysteroscopies in outpatient department. Limited options due to ventilations is becoming entonox. So gas and air, very popular sort of options, been there a long time, but we know that it's a occupational hazard, and a lot of hospitals now realizing that the rooms where they doing the procedures, not necessarily hysteroscopies, could be management of miscarriage, for example, where entonox is used a lot, that actually the ventilation standards are not safe, and a lot of places actually discontinuing the use of entonox now. Pemfrox, it's another inhaled analgesia option. It's called the green whistle. It's not very widely available, but some areas are starting to use it now. It's a self-administered inhaled sort of pain relief option, which I'll talk about it later in more detail because we'll be using that. And a very limited, very rare option at the moment is intravenous sedation for outpatient hysteroscopy. From my knowledge, there are only 3 hospitals in the country that are offering this for hysteroscopy, 2 of them as an outpatient option, and the Fair Trust offering conscious sedation in theaters. Now, what is available at Chelsea and Westminster Hospital? This is where I work. So this is just a few pictures. So paracetamol, ibuprofen, Pemfrox, the green whistle there you can see on the left at the bottom, local anesthetic, intravenous sedation, and we offer some complementary therapies, which I'll touch on later on. So we'll start a little bit more in detail on oral analgesia. So of course we do recommend paracetamol and ibuprofen as in keeping with the RCOG recommendation. However, we recently been looking at the use of Buscopan as well as an alternative. For example, if someone is allergic to ibuprofen or can't take it, Buscopan is a very good option. It's an antispasmodic medication. It can also be bought over the counter or we keep it in clinic. It is of license use for gynae, so we wrote a patient group directive for that. So we as nurses can administer that for gynae patients. And we find in it that is extremely useful prior to hysteroscopy and also post-hysteroscopy if needed. It targets cramps very effectively. It's not opioid, so it wouldn't make our patients drowsy or dizzy. They can drive, they can go on with their day as they plan. Now, the problem with that, there is no official recommendation that this is something that can be used. And what RCOG and BSG are currently saying that they do not support antispasmodic because of the limited evidence. And that just means there's not been enough studies or work done to look into that for different gynecological procedures. And I just put a little sort of a statement there at the bottom. Just last year, the RCOG was saying the same thing about intravenous sedation. The statement was the same, that intravenous sedation is not routinely recommended because it's not enough or limited evidence that it's effective. We know now a lot of emerging work across different areas and from abroad. For example, Australia, China, sedation has been used for decades there for sedation. For example, in Australia, sedation has been used for coil fittings for at least 10 years now. So just because it says that there is not enough evidence or evidence is limited, it shouldn't be limiting us to explore these options with you know, in our services and have a look, you know, do audits, look at pain scores, because the statement can be changed easily if there is enough evidence to say that it's actually effective. So local anesthetic, this is another option that we offer here at Chelsea. We use Cytonest because it doesn't have adrenaline, so the sort of side effect profile is better, especially for ladies who have cardiac problems, palpitations, or any sort of other contraindications. And it can be used for cervical, paracervical, or fundal blocks. Now, it's very rare, actually, that patients are offered all of these blocks. Now, your most common one is just a cervical local anesthetic, where, as you can see on the first picture, is just administered to few sites or to the external cervix. Now, there are 2 different ways of administer the local anesthetic. So you can administer, it can be administered deeper into the paracervical area. And I put some diagrams there because it really shows nicely how it really creates a better block and deeper block. So it really anesthetizes those higher uterine areas. And then with the fundal block, this is where we can numb the top of the uterus. So it can be used for ablation. It can be used for coil fittings when we numb the fundus, because when we fit the coils, for example, when the coil touches the fundus, this is the uncomfortable part actually, for ablations as well. Or, it's very easily administered. It doesn't require, interestingly, any speculum or any other vaginal instrumentation. It can be just administered vaginoscopically, so just through tiny telescope. And also, before doing any of those blocks and injections, because they are painful, what I do and what I sort of implemented is we use a topical anesthetic first. And I'll put a little paragraph there about the onset, because what I often see when I train doctors and nurses, they try and be obviously helpful and kind, and they say, okay, we put numbing gel or numbing spray before we do the injection. So that's great. And what happens next? They put the numbing gel. After 15 seconds, they go in with the local anesthetic. Now, that obviously doesn't work. Initial effect takes up to 3 minutes, so you do really need to wait. For that time, I would normally remove speculum, we just chat and, just wait out. And actually, the best time is about 4 to 5 minutes. And actually, my dentist taught me that, because I found the best dentist in the world. I can never feel when he does local anesthetic for me, because he really makes sure he waits 7 to 10 minutes after administration of the local topical anesthetic before he does the injection. So this is something to consider as well, that we need to wait for it to actually work. So in terms of local anesthetic, the purpose of it is to make procedure less painful, but actually to administer that, it is painful. So what is new in that area and what we are doing to improve that? So sorry, it's a busy slide, but I'll go through everything. So in terms of local anesthetic, it applies to many different procedures, not just hysteroscopy. That could be a coil fitting, that could be management of miscarriage. So before we administer local anesthetic, very often we need to stabilize the cervix, so we can actually able to administer it fully and deeply to numb the whole cervical canal. So the thing that is used to do that is called some sort of forceps, like tenaculum, valsellum tenaculum forceps, or Alice tissue forceps. Those are the most popular. Now, the picture with a little tomato, you can see how traumatic it is. Just looking at that, it's really looks really painful. And actually, this valsellum tenaculum were invented to retrieve bullets from the soldiers. So it's in my view, it does not have space in gynecological clinic these days for sure. So what we switch to is a non-traumatic suction-based tenaculum. So you can see with the little sort of tomato picture, the bottom picture, this is where the suction-based tenaculum is applied. So I put some links there. If anyone is interested, you can have a look at their website. I have no affiliation with the company or anything like that, but it has a really lovely video how it actually works. So you don't get that pinch. So there is not that pinchy feeling. So that is a great option to eliminate that as well when we do the local anesthetic. And also we are trialing a new speculum. It's a quite popular speculum right now. So we just got it into the clinic and we did a few cases with that as well. So the way it works, again, I put the link there. You can have a look at the website. But so far from my experience, that it really applies less pressure, because the pressure spread out evenly, sort of 360 degrees, because it opens like a little bouquet of flowers rather than just top and bottom like your classical speculum. It has a lot of benefits for clinician, but also especially the pressure distribution is so much better for the patient, and also it's very adjustable. So sometimes what I find is that I always go in with the small speculum because 98% of the time it is sufficient if you know how to use speculum. But sometimes you need a longer speculum, and actually then you have to take out the small speculum, go in with the long speculum. It's just a lot of in and out, and it's very painful. With bouquet speculum, the way it's designed, that actually it really, I know we say one size does not fit all, but with this speculum, actually, it does fit most of the sizes, and lengths were all amazing and individual and different. So actually with this speculum, I find that, it's sort of medium to long, even if needed, the way you use it, you can adjust it. So that's another good thing, a slightly more comfortable speculum and non-traumatic tenaculum. So that makes administration of local anesthetic, a little bit more tolerable. Next slide, please. And then another option, another pain relief option we are using is the Penfrox. We have been using it for a while now. So it's an inhaled analgesia. It is short term. It wears off really quickly, but actually the onset is really, really quick. It takes sort of 4 to 6 breaths for it to start working really effectively. So it's fully patient controlled. So, it really sort of on demand. You can use as much of it as you need. And there is a little trick how you can use it to get sort of even a stronger effect by closing, like there is a little hole at the top of the clear part of this inhaler. And if you place your finger there, you get a double strength of the sort of the drug. So it's very, very effective, and it's fully patient controlled. And, there is no limit of how much you can inhale throughout of the procedure. It's just on demand. And it's used for moderate to severe pain, and it's used in trauma cases. Historically, it's been used in A&E for like fractures and things like that. So it's quite strong. But actually, it does say at moderate to severe pain, but actually it really depends on what the patients want to do. Because how do we know that they'll experience moderate or severe pain? So some women prefer to see how they go and then have it on the standby if needed. Or some patients say, you know what, I'll just use it throughout regardless. If my pain will be mild or moderate or severe, I still want to use it. So, it's everybody's choice. It's about sort of 12 pounds, so it's not expensive. So everybody should be given an option to use it. Minimal sedation. So after procedure, after the sort of standard checkout, which is, 10, 15 minutes, observations, refreshments, if no kind of vasovagal episodes, from the hysteroscopy, rather than Penfrox, patients can go home as normal. The only thing that we're advised not to drive. So this information is given preoperatively, pre-procedure to all patients, so they're aware. And it can be combined with any other methods apart from sedation. So you can use local anesthetic with that, oral analgesia with that, and complementary therapies as well. So sort of everything can be used as a mix and match options as well. It's of license use for gynecology. This is why some units are quite slow to introduce it as well, because it requires a lot of paperwork, a lot of work with your pharmacist. But we've done that, and we've been using it successfully. Again, at the bottom there, I attached our Penfrox information leaflet if someone is interested, and I think Stephanie will share the slides so you can have a look. And also, if you Google Penfrox, and Google has a lot of information on their website. Inclusion criteria is actually very good. Almost everyone can use it, apart from patients who have sort of advanced liver disease, renal disease, transplants, cardiac disease, and if they on some certain medication. The list is about 5 of them, and it is extremely rare medication. I've never met anybody who's using that. And other than that, to be honest, everybody else can use it. So the inclusion criteria is very wide. Next slide, please. Another option we do offer here, Chelsea, it's a conscious sedation. And this is just a brief overview of everything. I can talk about conscious sedation, for another hour. So I'll just briefly touch on it. So intravenous sedation, as we all know, has been used across different specialities for decades and decades, especially dentistry, endoscopy, and as always, women's health is overlooked. Now, Chelsea and Westminster Hospital was one of the first trusts in UK to offer IV sedation in outpatient department. At the same time, when we started, another trust started offering intravenous sedation, but they were doing it in theaters. So it wasn't a sort of outpatient sedation, it was sedation in theaters. And then recently the third trust joined, I think, Manchester, from my knowledge. So it's 3 trusts in the country at the moment who is offering sedation. So in 2024, we presented outcomes and abstracts and a lot of work at BSGE. And at the same time, following that, we did some work with RCOG, where following which a recommendation was changed. Before, I think early 2024, the recommendation was still that intravenous sedation should not be offered as one of the options for outpatient hysteroscopy. However, after that, they have changed, and now they say that it can be considered as one of the options. Our sedation success rate is 99%, meaning that 99% of patients we've seen in sedation service tolerated procedure and successfully sort of went home, and there was no major side effects. The only sort of side effects which is expected with very strong medication, it's nausea, which we can target straight away by administering intravenous antiemetic, anti-sickness medication. So actually, it's an excellent option. The next slide, please. For sort of ambulatory invasive procedures. So what we use for sedation, we use a very strong opioid medication, fentanyl, and we use a midazolam, which is a sedative. On top of that, again, as I mentioned before, a lot of those things can be sort of mix and match options depending on preference. So we recommend to take oral analgesia prior to sedation as well. They can have local anesthetic, and there's a lot of other medications that can be administered intravenously directly during the procedure, such as different type of painkillers. But in the last 2 years, we did not have to, since we started, we did not have to administer any additional intravenous pain relief on top of sedation. It's just really effective. In terms of patient preparation, so again, I attached the leaflet there at the bottom, so if someone interested, they can have a look. But mainly 2 things. Patients need to be fasted for 6 hours. They can have sips of water all the way until their procedure time. And they can have black tea, black coffee for those who need, caffeine kick like myself, up to 2 hours before procedure. But we recommend that they don't put any sort of milk, honey, sugar, because that will act like as if you've eaten something. So all that information given to them. And the second thing, they need an escort, because, you do have a strong medication administered. So for safety purposes, escort is required. Same like if you have procedure under general anesthetic. Continuous monitoring throughout is implemented when we do sedation. So we have not just the cardiac monitoring, but we also do capnography monitoring. So it's, a lot of sort of safety protocols to ensure patient safe. And to date, touch wood, we had no issues, no airway problems. We do not need to do any interventions for airways or anything like that. We did not have to call any sort of support team or crash team or anesthetics because, again, very good monitoring and controlled environment that we have in clinic. Total stay for hysteroscopy under sedation is currently 1.5 to 2 hours. That doesn't mean that procedure takes that long. Procedure still actually takes 5 to 10 minutes. It's just all the preparation, consultation, because patient needs to be cannulated, and then debriefed after, and they need to mostly this time includes 1 full hour stay post-procedure in recovery area while the drugs wear off. Now, so that 1 hour is just that post-procedure rest and recovery, just for that sort of safety, one of the safety criteria, because the drugs need to be expelled by a sort of renal system. But the rest of things is just consultation, consent, and procedure itself. Inclusion criteria needs to be met for this procedure as well, because it's an outpatient sedation. Again, most women would actually qualify if they don't have a complex airway, if they don't have any sort of moderate systemic disease, either cardiac or respiratory. And BMI should be less than 35. This has to do with the management of airway, because patients with higher BMI above 35 class, they can be difficult to manage their airway if they over-sedated, if they go into very deep sedation when we need to take over their airway. This is not a safe thing to do in outpatient department. And as a result of that, what we now implemented is that we don't want to say to the rest of women who don't meet the criteria, oh, you can't have sedation, sorry. So what we implemented, instead of then saying, okay, GA hysteroscopy, we created a pathway where sedation can be done in theaters instead for patients who have those sort of complex airways or some medical history that is not safe to sedate them in outpatient department. So they are then sedated in theaters in controlled environment with anesthetist, where we have all the sort of complex airway equipment, and patients can always, if needed, they can be put under GA. Obviously, that's all part of the consent. So we also created patient information leaflet for sedation, and we run pre-procedure telephone clinic. So that's just to go through everything, to answer any questions, just like another sort of safety phone call before procedure, so patients are less anxious and know what to expect. And we have our email and our number, means my email and my number really, all the time, so they can contact us all the time. Next slide, please. This is just a little bit feedback I sort of gathered from our study. Now, to date, we have done over 300 sedations. The numbers are quite small because it's only myself and one other consultant who trained to do sedation, and we only have 1 day a week on Monday where we do sedation. We are working really hard to create more sort of capacity, but it's difficult in NHS, but we are getting there. We just trained another consultant and training 2 more nurses to do sedation. This little feedback I'll share here briefly. It's, as you can see, it's 71 patients. And it means that there is more than 200 paper feedbacks are still sitting in my office that I've not entered. So, the numbers will be changing and there will be more data. This is just as far as I managed to enter. So I'll just quickly give you a little sort of brief how patients experience the sedation service. So one of the questions, did they receive any written information, instructions, or where to look for information prior to their appointment? So out of 71 patients, they all received. Another question is, I was able to ask questions and discuss my any worries. So as you can see, everybody said yes. One patient was not sure. Another question was, I was offered an opportunity to discuss pain relief. That's very important. And I'm very happy to see that everybody agreed with that. I felt involved in the decision regarding my care. That's, again, very important. It's all about, informing patients about, the duration, how things going to go, that they can stop. It's just that they informed throughout and involved and feel in control. So again, everybody agreed or strongly agreed. So that's great. Next slide, please. A few more questions. So I was treated with respect and dignity. Of course, that is very important, and everybody agreed with that statement. Staff explained things in a way I could easily understand. I think that's very important because we cater to a lot of different individuals. There could be language barrier or, hearing problems. There's a lot of sort of diversities, and it's, some people may be able to talk to us in a very sort of medical fancy language due to their background, but for someone, you just need to sit down, draw a diagram. This is what I do. I have a lot of printout of the uterus in my clinic on the desk. And I just take a pen and say, okay, this little circle there, this is the polyp. This is how we can remove it. So I sort of show it by drawing. It's my preference. And I can put measurements there as well. And then a lot of my patients then say, can I take this picture home with me? So we always laugh because it's just scribbles, but we find it useful. Another question was, overall, how was your experience of our service? So 69 patients said excellent, 2 patients said good. And then overall, how would you rate the care you receive? So it was 9.74. So again, quite a good number. Next slide. And I just put sort of preliminary results here just to compare normal hysteroscopy from the data we have. And currently that is over 500 patients. So from normal hysteroscopy, the pain score is 5.13, which is same like national score. I think nationally it's similar everywhere. And then with sedation, it's 3.4. Now, again, bearing in mind, this is only 71 patients, and I just need to enter the rest of those questionnaires and keep entering and just seeing how that number will be shifting. My prognosis that it will go to 2, because even from last Monday, we did 8 cases. We did 8 hysteroscopies under sedation, and the pain scores were 0, 1, or 2. So there was no higher than 2. So this was really, really great. So we are reducing the pain score. It's reduced by 2. And, I'm predicting it's going to go even lower. We are doing a very big study right now where we're comparing all the options as a standalone that we use here in Chelsea. And then we're comparing mix and match options. So, for example, virtual reality with local anesthetic and inhaled analgesia, or sedation with oral. So it's a lot of paperwork, a lot of sort of patient feedback. So it's probably going to take us 6 to 8 months to process everything, but it will be really interesting to see, what it will tell us. And by all means, I'll be happy to come back and share with everyone. Next slide, please. This is just, again, a little bit, I just wanted to mention that there was a first sedation symposium in UK that was organized in September 2025. It was first ever event like that. And there were about 250 delegates from across the country. And out of all the delegates, myself and Mr. Flint, as you can see there at the bottom, he is our sedation lead consultant. We are the only 2 people representing gynae and women's health. Everybody else was from dentistry or endoscopy. So it was really shocking, really, really shocking. So definitely we need to, work more exposure needed. And I think the fact that RTOG changed their statement now, given a green light to a lot of places to work on implementing sedation. And just yesterday, one of my colleagues from up north requested a meeting with me because she is planning to implement sedation. So she wants to get advice. A few days ago, I had a phone call from one of the consultants who was asking me about sort of advice how to start using Pemprox in clinic. And then back in December, I had another request to meet to discuss how to start sedation service again in another hospital somewhere in the country. So this sort of things are getting a bit of traction. It's just about talking about it, sharing knowledge, meetings like this. We just really need to do more work because it's quite shocking that sedation, intravenous sedation, has been used in NHS for different procedures for at least 50 years, and only 3 hospitals offering it for gynae in the UK. So it's very shocking. Next slide, please. And just a little touch on complementary therapies. I have underlined complementary therapies because it's an additional thing rather than replacing any true pain relief option. I just really want to make it really clear. Now, it's important to sort of create a nice environment which is relaxing, where you can have those, conversations with women, with patients. You can build trust. It's so what we use sort of to create a nice ambience and a friendly, welcoming atmosphere. We use music, we use light installations, we use aromatherapy, which is very popular. So we have a little diffuser which patients can choose different oils, and also they can have like a different type of aromatherapy oil on like a little cotton that we can just have with them and just sort of sniff throughout the procedure. The most popular one is, of course, lavender because it's really good for relaxation. And of course, on top of that, patients having, Pemprox, sedation, everything that they like, but it just creates a really nice sort of atmosphere and makes patients feel special. I put some comments there that I will read out because it just really does make a difference rather than coming to sterile, extremely bright clinical room. It just, creates a lot of anxiety. So one of the patients said, such a lovely touch to have music and diffuser in the procedure room. It really helps to create relaxing atmosphere, as well as the warm hand I could hold. As a person who works with mental health, I understand how important is care and connection and ambience in the consulting procedure room. When we feel comfortable, we relax and feel less pain, and the healing afterwards is quicker. I could say that today I experienced a future care, so I keep my fingers crossed that it will transfer into another NHS settings and not stay only in Irina's and her team's consulting room. Another patient said the soothing background music was an added bonus, helping me relax during the procedure. And another patient said about the virtual reality, I was expecting the administering of that to her, but it barely did because I believe of the VR headset I was offered and the clever way the team manually triggered new images at the moments of likely pain or discomfort. I think it also helped that she was doing deep breathing and slowly, and the jazz playing helped me to be calm enough to breathe deeply. So we also using virtual reality as part of the options that we'll be comparing for anxiety, pain, sort of distress, emotional comfort, where we'll be evaluating all options, oral analgesia, local analgesia, and also virtual reality is going to be part of that. And actually, it's not for everyone, but it's very popular option actually, and a lot of people like it or just want to try it. And we have like a guided meditation, or you can just look at the nice calm images. You can be on the beach. It's really lovely. It's not for everyone, again, but this is just catering to any possible patient request or needs that we could think of, and it's working really well. Again, we had to write all the paperwork, the leaflets about this, so patients are informed, because if they don't know they can use it, they're not going to request it. So again, those are the links for the leaflets that you'll be able to access. Next slide, please. And a little bit about consent. So when I started at Chelsea in hysteroscopy in 2022, what we had is your standard yellow consent form where the clinician scribbles 2 lines with the writing you can never read. And there is no really detailed explanation there of risks and sort of percentages of those occurrences, like the likelihood, and it was really sort of outdated. So what I introduced in hysteroscopy service is digital consent. I put again a little link there if someone is interested, you can have a look. It's called Concentric. So all patients receive digital consent at least a few days prior to their procedure via Concentric. All relevant leaflets can be uploaded to this platform and attached depending on what the patient is having. So for example, if I'm doing hysteroscopy, biopsy plus minus polypectomy, so I would send the information about procedure itself, all the risks, then I will attach the leaflet about polyp what is it, and all the sort of information about that. I will attach all the pain relief options for that patient. So pen frogs, sedation, virtual reality, all of that. I will also attach information about that, about virtual reality, about pen frogs, aromatherapy. So they have so much information to look into and to decide for themselves what they would like to try. And then all those options are listed there and described in a lot of detail. And this company, the Complementary company, they constantly updating their platform. So they're getting better and better. And now they're adding some sort of images as well, animated sort of images of polyp or how it can be removed. So it's becoming clearer and clearer to understand for someone who is not medical. And then with this consent, it actually pings to you as an email, as a text message. And you can see right away there is all the main information. So hysteroscopy advice, email and number, and reminders to take any painkillers, reminders of location where you need to come, and all the numbers if you want to reschedule your appointment. And of course, when the patient arrives to clinic, if they sign the consent at home, it doesn't mean, okay, let's go. You need to go through everything still, confirm understanding, ensuring, any questions are answered and all discussed and confirmed and everybody is happy and know what's happening. And I got a little sort of snippet from their Concentric website. They did a study themselves as well, and they compared decision-making between clinicians and patients when clinicians use paper consent forms to when they use a digital consent. And from their study, they showed that it went from 28% to 72%. So that's very good. Next slide, please. And of course, just a little touch, it's part of the consent, but I just really wanted to touch on that. All clinicians I train, I talk to them now about trauma-informed care. A while ago, it was a very new thing for me because actually I was never taught about this, what is it, in nursing school. And I was never taught about this in hysteroscopy course. So any sort of official education I've done in nursing or in gynecology, any courses I have done, and I've done a lot, there was never anything about this topic. So I became very interested about that. And now anytime any doctors who work in my clinic or any clinicians I train or registrars or nurses, this is part of the kind of training bundle. So the way I sort of explain it's an approach that recognizes the prevalence of trauma and seeks to avoid sort of creating even more trauma during the clinic consultation or procedure. And it's all based on sort of safety, trust, and empowerment. And I kind of use three things. So what you focus on, what you do, and actually what you do after. So the main focus should be on physical and emotional safety, trustworthiness, transparency, choice, control, and collaboration. So, it's all well and good. You have all these options, all these aromatherapies, but in the end of the day, everybody is so different. So you have to be transparent, and I say, look, it's not going to be pain-free. It's not a nice procedure. You may feel vulnerable, you may feel exposed, but we try, we see where we get. If we need to stop, we make a different plan, So it's always important to kind of be transparent that, it's not going to be like this because you don't know how it's going to be. So and having that ongoing dialogue throughout the procedure with your patient is very important. And then what you should do, explain everything step by step, clear language, ask permission, offer choice, suitable pace. Sometimes people say, okay, let's just do it. That's it quick. Sometimes you need to take time. Encourage verbal feedback during procedure, which I mentioned on. Pause, stop whenever appropriate. And then aftercare, debrief and explain everything. Obviously, check how patient felt, if they okay, and provide clear instructions, any follow-up. And as a standard, myself and now all colleagues who work in my clinic, our patients sort of go onto this unofficial PIFU. PIFU, it's a patient-initiated follow-up. So we call it sort of unofficial PIFU. This means that after procedure, regardless of what duration of time that will pass, weeks, months, patient can contact us for request a phone call, for discussion, or just ask a question, or email. So after they leave, they always have that point of contact with us, and it's all the details how to contact us listed in all our clinical letters. So they all have that information. Next slide, please. And this is I put for the last sort of thing to discuss, because with all those options, regardless of what we are doing, we're still doing those invasive procedures. So what actually, just thinking outside of hysteroscopy, what can we do to actually not just improve that, but improve diagnostics and avoid these procedures? What sort of tests we can invent, or scanning techniques, with AI now and all these other options, to move away from actually having hysteroscopy. From our own clinic, we see 250 patients a month. And out of those 250 patients, one, sometimes two a month will be diagnosed with cancer, one or two with simple hyperplasia, one or two with atypical hyperplasia. So that's about 6 diagnosed with precancerous or cancerous cells out of 250 patients. So do we really need to do the rest of 244 hysteroscopies? So one of the pilots we are currently running in the trust as well. It's not a pilot anymore. This is called a with easy test. This is a diagnostic sort of vaginal swab to detect cancer. And the aim is to reduce unnecessary invasive procedures. So this was developed by the UCL researchers, and it's a non-invasive vaginal swab. For that, you have to use a speculum that detects endometrial cancer by identifying DNA methylation markers. It accurately triages women with abnormal bleeding, reduces false positive, and avoids unnecessary procedures. And there's a lot of trusts now that are starting to use the swab. So again, I put a link there to the website, but actually this diagram, it's very, very helpful, because if you compare a scan or and the swab, you can see that the swab is so much better. The swab results are on the right, so you can see the difference in false positive actually, and that just reflects what we are seeing across different hospitals, across different areas in the country, that less than 5% of all hysteroscopies that are done per month will be pre-malignant or malignant cells. So 95% will be normal. So actually, this is one of the ways of thinking about moving forward, thinking about the future. There is another thing that currently being developed in Italy. It's just sort of in a very sort of embryonic stage still, but what we are trying to use AI and like a specific scanning technique which can identify through the scan if those cells are cancerous or precancerous, or if they are normal. So we don't know, hopefully 5-10 years, I'm hoping 5, that perhaps I will lose my job and there will be no more hysteroscopy, which is fine. I will go into research. But, so there is, it's all good and well to try and, develop all these painkillers and all these methods. But actually, what can we do to eliminate hysteroscopy completely with, modern age, AI? There is so many opportunities. So I think that's my last slide, to be honest. Oh yeah, this is just, again, for you to have a look how the pathway works, how we do the test, if it's positive, if it's negative, it's you can have a look in your own time. So yeah, I think that's it.